Good morning, everyone. I'm Mariana, and I'm the Clinical Research Fellow working in Oxford with Antonia, and I'm having the pleasure to develop and implement the Fit for Labour, and my background is being an obstetrician in Oxford as well. So today we thought to give you a little bit of a taster of what we are doing with the Fit for Labour in Oxford, and focusing more on usability and feasibility. So I'm sure I don't need to tell you much about our background and why we need something like Fit for Labour in our lives as doctors and midwives, but I want you to focus on that number, on those 1,000 babies that each year in UK still sustain brain injury and die. These babies are supposed to be healthy, or we think they are healthy, when they go into labour, and for different reasons they sustain brain injury or actually die. And a lot of the cases, when you look into these deaths, you will see that a lot of them would be avoidable if we had better ways to make decisions, to monitoring, and of course this causes a huge impact in a lot of people involved, from patients, families and NHS. So why are we not doing a very good job as doctors, and midwives, and I think because I'm a doctor I can say those things. And I think yesterday a lot of people touched on the labour, and from Austin to all the other speakers, they said that labour is supposed to be an intermittent point of oxygen deprivation, of asphyxia. We are supposed to, as babies, to be stressed even before we are born, which is very funny in a way. It generates a lot of reactions from catecholamines, cortisol, all of those nice hormones that are important to prepare us for when we are born, to give that first gasp of air. And all of this is very normal. The problem is that perhaps not all the babies are the same when they start labour. And some of them potentially already have pre-existing injuries. They may have an infection, a bleed. They may not be exactly healthy when we put them go into labour. And some of them are probably more vulnerable. They may be smaller, they have placentas that don't work as well. And we have to think, should they all be in the same box, in the same sack, that they all are fit to labour? And the other problem, the hurdle that we have is, for the last 60 years we have CTGs, and they haven't changed much. We are better interpreting them, but we are still not quite there as yet. And working Delivery Suite, as I work for the last 10 years, we know how many discussions we have. There's a lot of intra-variability. Sometimes we don't even agree with ourselves in different times of the day, if we are tired or if we are in a night shift. And also there's a lot of risk factors that influence these CTGs. So what is the idea of the Fit for Labour? The idea is to create this decision support tool that is based on data, on computerized CTGs and on risk factors. And we want to have this tool to help the doctors and the midwives to make decisions and to screen for those little ones that already have pre-existing injury or they are more vulnerable at the onset of labour, and to make that question pop in our heads: do they actually can labour? Are they actually fit to labour? And to provide them with an individualized risk score for severe fetal compromise at birth. So this is the idea of our Fit for Labour. So this is just for you to have a think on how would this work in our delivery suites. So you have your CTG at the onset of labour there, and you have to have a reason at the moment to have the Fit for Labour. It's high-risk pregnancies. And you have the Fit for Labour running in a tablet, in a PC, and you add your risk factors of the mother and of the baby, and you'll get an individualized risk report with your score. And this is a little bit of my research that I'm doing, and that crazy person running over there, it's me with a tablet, with my team and Antonia behind me, wanting to work and move forward with all of this project. And you have a lot of things that I'm doing, and today I'm going to focus more on the usability testing and co-development, because that is definitely an important part of our project, to involve the people that are supposed to use it. If the doctors and the midwives don't like your tool, they won't use it. And I'm going to tell a little bit about the feasibility and the proof of concept and of the implementation that we are doing in Oxford and later on in Aylesbury and Birmingham. So just focusing on the usability testing, I'm sure I don't need to say much about usability testing, but it's a fantastic method that we have in evaluating a tool, a website, a device, whatever you have, to see how ready it is for your real users to enjoy and to complete the tasks as it's supposed to be, they are supposed to be completed. And has a lot of very good advantage and covers your problems of your design. You can find opportunities to improve it. You learn what your users like. And actually I added this number number 4, which is user-centric, and that's one of the reasons as a doctor I'm in this team, is to make sure we don't forget that this is for the doctors and the midwives, that they need to be in the center of all this project to make sure that we are very well represented and we like this tool. So this is what the usability testing looks like. I have run 6 sessions at Oxford so far. I had a mix of different clinicians, 7 midwives and 5 doctors, different ages, which was important for us, different grades. I run them with one of experimental psychologists to guide me through this journey. And all these sessions, they were done in a very structured way. They had an introduction, a pre-recorded video, and we gave them 4 scenarios with the Fit for Labour, and they had to complete the scenarios. If they couldn't complete the scenarios, they were asked to move from that question after 3 minutes. We wouldn't help them. We finalized the scenarios with SUQ questionnaires, which are single ease questionnaires, and SUS questionnaires at the end of the tasks. And the second part of the usability testing would end with the focus groups that normally was supposed to last 30 minutes, but because people had so much to say, sometimes they lasted almost up to 2 hours. And then we finalized with a conclusion. So this is just one slide on some of the results that I thought would be interesting to put here. So this is at the end, you can see that multicolored scale scoring from 0 to 100. And normally in the industry, if you have a device or a tool, if it is above 60, is above average, is almost quite good to be in the market. And if you have above 80, is excellent. And we started the first usability session that we did with 77.5, which is the first purple arrow on the bottom. Should I try? Yeah, over there. And that is a very good starting point because we already worked for almost 2 years on the tool, but we still wanted to do better. So with that feedback that we had from these usability sessions about what they like, what they didn't like, the interface, the buttons, how they wanted to perform, we kept improving. And each time we did a usability session, we kept improving the device. And at the end, in early this year, in the last usability session, we managed to go up to 85.8, which is on the excellent interval. So we like to think that we are quite in a good place at the moment with our tool, and you can see that we are trying to incorporate the feedback of our users. Of those focus groups, there was a lot of work involved in this. What we did was we recorded the audio of those 6 sessions. We have a lot of audio, a lot of hours of people talking about Fit for Labour and tools. And what we did was we coded inductively with 3 people. We coded the data into group themes and we developed codes. And then we analyzed them. So what you can see is a lot of information I can completely understand, and this is the simplified version. You have the pink balloons are what the midwives' topics that they were concerned, and they mentioned a lot of the times. We have the blue is the doctors, what they think about these tools and what they thought about the Fit for Labour. And we have the overlap topics that they both thought the same things. So I'm just going to pick on some of them. So for example, training. Both of the midwives and the doctors thought training was very important. They wanted to know a little bit more about the tool, how it was created, how it's supposed to be used to make sure they are using it in the right way. So definitely that was one thing that came up several times in these sessions. Escalation for midwives is another topic. Midwives liked the idea of having a number and something to ask to show to the doctors to make sure they would grab their attention for them to come to them much quick as they can, because sometimes doctors are difficult to get in delivery suite. So it will be a very good tool of escalation. Also, the midwives mentioned that it would be good if you are a junior midwife and you are indecisive if you should send the patient home. So this would be a good tool to give them that safety net in kind of the cases they were indecisive. From the doctor's point of view, I think they focus a little bit more on different aspects, more on where would the Fit for Labour fit their clinical pathways. One of the things that came up several times was reassurance for cases that were borderline if they weren't sure what to do, and this would help them to cover them for legal consequences. There was a lot of conversation about between inconsistency, if the doctor thinks one thing and technology thinks another thing. Where do we stand with this? Who takes the last decision? There was some worriness that this could increase interventions, but overall, for both doctors and midwives, we had a very good positive welcome to this kind of tools. And the next table, you see a lot of data. I don't expect you to read this, but it's quotes and how we got to that tree, and a lot of information more detailed about the doctors and midwives and their views. So what is next in terms of usability? So next, we are going to two different places. We are going to Birmingham and Aylesbury. One is a district hospital, big hospital, and the other one is a smaller hospital. And we want to see if this tool that we developed actually would work well in different geographic areas of UK, and see if they like it and what are their thoughts, if it is the same. Are they open to research as we are in Oxford? And we also want to analyze this and come up with some conclusions. So a little bit about the Fit for Labour, the study that I'm running as a proof of concept. So far, what we are doing is we are recruiting in Oxford. You can see that I have had 47 participants so far enrolled in the study. Our idea is to test feasibility. We are not testing if the tool performs well. We are wanting to test if we actually can get to those reports. We want to test if there is appetite from the patients, if they are interested, what are the opinions of the clinical staff, if the connectivity works. And you can see that I had a lot of issues from me having a baby in the middle, having problems with my contract, having a different system in Oxford in the middle of our recruitment. But all of that, we managed to keep going, and we are doing very well at the moment after 2 amendments that I now can recruit everywhere in the hospital, everyone that is in early stages of labour. So I just put some numbers just to have something to show, but this probably doesn't show much of our data, but of the 47 patients we have, our mean maternal age has been 31 years old, so there is a good young cohort of patients. We have very good nulliparas and multiparas, a good balance. In terms of inductions, I have recruited more in inductions, and I think it's quite easy to understand the reason for that. It's much easier to speak and recruit to people that are being induced after 1 or 2 gels than actually someone that is in full-blown early stages of labour and in pain. So I just thought that I would end up with 3 slides that I would like to ask for you to think and to come and help me, to come and find me of the things that, the challenge that maybe I've been facing as a recruiting and as a doctor. One of the things has been, of these 47 patients, I had 2 patients that they were very lovely, and they said, I'm really happy to recruit for your study, doctor, but I don't want to know the outcome. I don't want you to tell me what is my risk. And it's very interesting. And I think from this scientific audience, we all love numbers, we all love percentage, we all love to predict the future. And having patients telling you that they don't want to know about what you are doing is very interesting. And I think one of the thoughts that I have about this is we have to think that we are doing this for the patients. The patients are in the center of what we are doing, and we have to think about a possible pathway that we actually take what they are saying and respect what they want, and make sure that we take this into consideration in the future, that I will find more ladies that potentially don't want to know about their risks. The second thought that I have here is, having been recruiting in delivery suite in very dark rooms, it's very interesting to come and approach someone that is in all fours or inside of a pool and recruiting and telling them about the risk. They are very sleep deprived, they are in pain. You have a husband that is probably suffering from PTSD in front of you. They don't understand what you're saying. So it's very interesting how you communicate and finding a way of passing your message, of passing all of this work, all these numbers that you are telling them, and making sure they understand. So I think here the key is communication. You need to make sure you are doing the best that you can in communicating these numbers and this information to your patients. And potentially here the training is very, very important. And my last thought that I have here is how risk perception affects our patients, and it's so different. I may have the same percentage, the same risk, and I go to 2 different rooms, and both the patients have the complete opposite reaction to the risk that I tell them. I may go into one and they say, fantastic doctor, I'm doing so well, I have a healthy baby, and I go to the next door and the woman almost starts crying when I tell her the risk. So one of the things, and I'll just finish with this slide from Ali Stiles, is the risks that we fear the most. And yeah, I put them in red because these risks are all related to labor. And maybe I'm telling them a number, but at that time they are so afraid of things going wrong. And you can see that all these risks, they actually potentiate even more. So just to have that in mind when we are communicating risks with our patients. So I'd like to thank for all of you to listen to me, and thank my fantastic team that is always supporting me and making me go forward. Thank you.
Thank you so much. Very interesting.